Welcome, everybody, to the HHQI Underserved Population Network webinar. Today's session, we're very excited, is called Making the Most of Telehealth to Care for the Underserved Populations. We'll be looking at the 4 pillars of a good telehealth program: the right technology, the right staff, right patients, and financial support. So I'm very pleased today to introduce our speakers. If we could have the next slide, please. Okay. And today's speaker is Alexis Silver. She is currently the independent health technology consultant working collaboratively with a large long-term health care provider in New York City and a technology company to develop innovative new monitoring devices to support aging in place. Prior to becoming a consultant, Ms. Silver was the VP for Clinical Policy for the Home Health Association of New York. She is the past president of the American Telemedicine Association Home Telehealth and Remote Monitoring Special Interest Group, and serves as a liaison to the Joint Commission Professional and Technical Advisory Committee and representing the American Telemedicine Association. She is a graduate of Syracuse University's Newhouse Communications School, studied at Sage Graduate School and Empire State College, which was health policy, and received an MBA from Exeter College. So with that, I'm going to turn the presentation over to Alexis.
Okay, thank you. I'm going to apologize in advance for any mistake I might make. Here in New York, we call Medicare certified agencies CHAS. I'm going to try and avoid that term, but if I use it, my apologies. I know it's just inherent to New York. So I try to train myself not to use that terminology. And I'm not going to spend much time on what an underserved population is. We all know, you all have them wherever you are, whatever state, whatever region. Most of what we deal with are probably collectively called dual eligible. We know they're expensive populations to care for, not just for you, but for the federal government. And part of what I want to talk about today is using telehealth to reduce your costs for caring for those populations, and also, from a broader perspective, reducing the overall cost of care. And one of the things I've noticed in a lot of my work with home telehealth is that when it works really well when it's provided correctly. It has incredible outcomes, but many programs are not really well designed. And I'll give you the best example are those telehealth programs that were based on grant funding years ago. Organizations received their money, they got their telehealth units, they used them for 2 years, 3 years. When the grant funding went away, they just put them on the shelf and never used them again. And I've talked to many vendors who are just really frustrated about that. And the problem was that without that grant funding, there was no fiscal sustainability built into the program, even though during the grant program, it probably would have been helpful if people spent the time and energy to try and integrate it into the program. Unfortunately, that was often not part of the grant requirement. Here in New York, we had grants years ago. Many of them were written by vendors. They were awarded, and to providers who really hadn't spent the time and effort to look at how they were going to successfully integrate that technology into their overall program. And I have many horror stories, which I won't share, about along those lines, and I'm sure some of you know just what I'm talking about. So one of the or probably the major rationale for telehealth is that, one, it improves outcomes. It keeps your patients healthier. It reduces hospitalizations. And when patients are hospitalized, they're traditionally hospitalized for a shorter length of time because there's an earlier point of intervention. Telehealth can improve nurse efficiency if you're monitoring large-scale numbers of patients, if you are able to make your visits clinically driven rather than calendar driven, you're already improving the efficiency of that nurse's time. One of the things that patients say in their satisfaction surveys is they actually had a better quality of life. They felt safer at home. They really liked the interaction with the telehealth nurse. They felt like it provided an additional level of care. That's not something that we can put dollars on, but for those of us that are clinicians, that has enormous value. And I've always said my catchphrase is telehealth can save lives, can save time, and it can save money. And this is just, I'm going to represent what I call kind of a conceptual vision of telehealth in a couple of ways. You know, some people like to look at it as intersecting, all these pieces intersect, and yes, they do. These are all moving pieces that impact, you know, the value and the success of your telehealth, and of course, always the cost, because telehealth costs money to provide. A lot of times those savings accrue to Medicare, to Medicaid, to the hospital, not necessarily to the home care providers that's actually paying for the technology and the labor costs involved. So this is one of the ways I look at a telehealth program, and this is really kind of the way I'm going to approach it for this conference today. And it's just looking at having the right pieces so that your program can be as successful as can be. And it takes all these different pieces, and they're not independent. In other words, they're all interlooping, but without them, your whole program is going to suffer. One of the things that I talk to providers about when they're looking at telehealth programs is, well, what do you want to accomplish with this program? Because it's not just like you're buying a package and setting up a telehealth department. Like, what do you really want to get from this? Because that's going to impact the way you're going to set it up. And for those of you who write grants, who have ever heard me talk about doing grant writing, it's like you need to start with the program before you write the grant or before you buy the technology. You kind of need to know what you want, where you're going to go. I mean, these are all valid outcomes: staff efficiency, patient care is better. Are you looking for more referrals? Today in this world of ACOs, there are many ACOs looking to home care agencies, looking to telehealth programs to help them collectively and collaboratively reduce hospitalizations. Are you looking to increase your revenues? Beyond that, what patients are you going to serve? And you know, underserved populations has a huge breadth of patients. Are they going to be pediatric? Are they going to be elderly poor? Are they going to be rural elderly? And that's just the socioeconomic piece of it. Beyond that, what diagnoses are you going to look at? What buckets are you going to put your patients in? Because, again, that's not going to just affect your program. It's going to affect the technology you're going to choose. We're going to talk about that shortly. Another piece, how is the program going to intersect with my other programs? A lot of times telehealth programs have been set up as freestanding and not necessarily have been built to integrate as part of the regular flow of a home care agency. There'll be a telehealth nurse should be at a separate desk. Today, we're learning more and more that more providers are kind of integrating it. Although there's a telehealth program, it kind of infiltrates, if you will, the rest of the program. What staff is needed? Staffing reluctance has traditionally been one of the major barriers to a successful telehealth program. Not all nurses or staff members believe in telehealth. Not all policy members believe in it either, for that matter. But who are the staff within your organization that's really going to get behind this? I remember years ago going to talk to a PACE program with a provider, and the provider was going to donate some used telehealth equipment to the PACE program. PACE program nurse wanted nothing to do with it, even though on one hand she was complaining, about all the clinical intricacy of her patient. She didn't want to learn about telehealth. It was too much effort. And little by little, we're getting over those obstacles with staff, I think, but you still have to make sure that you have the right people who are invested in your program. First, the big question is, how are we going to pay for this? How much money can I spend? How much money can I save? Technology. And of course, finally, what's really important? What are you going to measure, and how are we going to measure that? So patients, this, at first you think choosing patients is an obvious choice. But it's been interesting just working in product development, like trying to target the right patients for the right technology, and that it's not as easy as it may seem at first. Traditionally, telehealth accrues the most cost savings with the sickest patients. However, we're learning that some patients may be too sick to really benefit from telehealth. Or in some cases, if you're trying to establish a pilot program, you may not want, and this sounds terribly discriminatory, but you want to have a homogeneous population so that you can compare data. Dialysis patients, for example, have a very high rate of hospitalization. Typically, younger disabled people who are on Medicare have a higher hospitalization rate. So especially if you're looking to target and pilot a program, you might want to very carefully choose the patients that you have without being discriminatory, of course. But you might want to just say, we want strictly heart failure patients. We do not want X, Y, and Z, because we want to test that. You just want to be kind of pure about how you go to manage it. We all know that telehealth does very well with heart failure patients, diabetes patients, COPD patients, as well as a breadth of others. But those are the most common that we're working with still. How motivated are your patients? Huge issue. If they're not going to be motivated, that technology is not going to help them. What language do they speak? Again, another crucial part. Do you want to pay a translator to call them every day? If they're not, if they're red alerting, do you want to be able to speak with them? Do you have a bilingual nurse or trilingual nurse, depending on where you are? Does your technology support that language? What connectivity do they have in common? Because again, this goes back to your technology that you're choosing. There's now many more options as people, traditionally it was old plain old telephone or POTS lines. Many of our technologies still rely on that, but now there's internet connectivity, there's cell connectivity, which is not always the only or the best answer depending on where you are. One of the things that I've learned, and if I'm talking too fast, please slow me down. I'm from New York. I talk fast. I'll try and check myself occasionally. One of the needs that when you're looking at setting up a program, you want patients that are capable of learning to self-manage. And in the end, one of the goals of telehealth is not just to monitor patients, but to educate them and teach them to self-manage. So you kind of want to look at that from a broader perspective as far as motivation, as far as your screening tool, which I'm going to talk to in a minute. And again, in order to, if you have a telehealth program, you know that your nurses spend a lot of time looking at red alerts and also a lot of times calling patients, and maybe you have a tech or a receptionist who's calling those patients and reminding them to respond. You want to minimize that to the fullest extent possible. Traditionally, agencies will get people either to respond every day, 7 days a week, or maybe 3 or 4 days a week, depending on your patient. You want to look at that as you're developing your program. And it's a way of saying, well, what bang can we get for our buck? How many days do we need that patient to respond to make sure we're providing the best quality care? Is there too much data? Is there not enough? If they're acute, it's going to be more often. So again, just to summarize the piece on patients, when you look at patients, you want to say, well, which ones of our patients are going to benefit? And the real answer is maybe not all. And I want to make a special word here about behavioral health patients, which I know we've run into recently in one project I'm working on where people were paranoid. They were taping over all the lights on everything. They thought they were being, distributed on the internet. So you probably want to screen for behavioral health issues when you're looking at your project or looking at your program. They're doing a lot of video with behavioral health patients, and there are some that's very successful with. So what I'm going to recommend is that as you develop your program, you develop a specific screening tool that will help save you a lot of time on the back end as you go through and start selecting patients, as you ask your nurses or physicians to refer. These are the patients that are best for our program. These are the patients we're set up to serve best. It doesn't mean that you can't change your screening tool, that you can't, adapt it. But I think if you're starting, you might want to look at this objectively, because it's also going to help you have that conversation within your organization about what your best target audience is. Again, if we're dealing with underserved populations, we may be dealing with people who've been outside of standard health care. We're going to find within our new, open health insurance, you're going to have more people coming in. It may offer you a tremendous opportunity as far as business. However, you want to make sure that you're doing it without, one, to use the terminology, driving yourself crazy or losing money unnecessarily. And one of the questions, too, that about in your screening tool, if you have people that live alone, they may not be able to use the technology on their own. They may have trouble standing on a scale. That doesn't mean you can't get them a steady scale to support themselves, but can they actually get on it, get off it? Those are the kind of things that you might want to think about. Can they take their own blood pressure? So, again, just throw that in as far as choosing a patient. So, technology. And I'm going to spend a lot of time on choosing your technology. Probably the two major costs in your program are going to be, one, labor, of course, and two, the technology. And generally, the technology kind of overrides things, because once you select the technology, you'll tend to have that for 2 to 3 years, so you have a commitment to it. And you really want to make sure that you're choosing the right technology now that you've looked at who you're choosing for staff and for patients. What technology is going to fit best within those preset parameters that you've chosen? For those of you who've been in telehealth a long time, you know that the equipment is evolving. I go back to the days when there were, little tiny pictures and cameras and proprietary, very expensive units where the nurse had a central station and had to go to that station and do a video with patients. Video is now coming back, but it's much cheaper. It's integrated into your computer often, or some kind of tablet. Much easier, much smoother. We have, of course, just the basic remote monitoring, which means it's maybe biometrics only. There's basic monitoring that may be questions only, and I'm not going to be mentioning any specific technologies today, so I'm struggling to describe these products without using the vendor names or the equipment names. Then you have the basic remote patient monitoring, little box with dialogue capability. We have tablets, we have video, we have IVR, which is interactive voice response. For those of you who aren't familiar with that, it's being used to do reminders. And in some cases, it's paired with self-measurement of weight and blood pressure, which is then self-reported by phone. It's probably the least expensive of these technologies. Of course, M-apps through your phone, which are really, really beginning to develop. There's hundreds, if not thousands of them. And I think we're going to see a lot of shaking out with the mobile applications, if you want to call them that. You know, many are consumer-focused, but there's also clinical-focused ones. And in some cases, we're now developing the mobile applications that support the remote patient monitoring tools so that a nurse would be able to view all that from her cell phone, would be able to go into the remote portal and view her patient's records. So again, for technology, there's some that are just for a single disease. Again, they might be just strictly for heart failure. They might be intended just to measure a person's weight or fluid balance, or in some cases, diabetes related. And then, of course, most of the products are meant for a more complex patient, take blood pressure, weight, pulse ox. And that's a more typical type of technology. One coming up new is the social platform, which really is more engaging for people with as far as calendaring, scheduling them, giving them the opportunity to use Skype with their families. It does not have a huge uptake yet. It's being used more in assisted living facilities to encourage that, or to help with the social isolation that people get as they're aging. Kiosk, which is a multi-user technology. You often see something like that. If you're not familiar with them, if you see, at your pharmacist, the place where you can take your blood pressure and weight and sit down, a kiosk is kind of a more sophisticated system of that, would provide the same level of functionality that a remote monitoring unit would have, but it can be used by many people over the course of the day, usually HIPAA compliant through a swipe card or specific access code. And again, they're getting used in a variety of places, often senior centers, daycare centers, that kind of thing. Connectivity, huge issue. We're going to be talking some more about that. Acquisition. Are you going to purchase it? Are you going to rent it? Are you going to lease it? Or are you going to outsource it? And those are major issues. And when I say outsource, are you going to have someone else actually perform the telehealth for you? There's a lot of collaboration going on. There's many for-profit organizations that will be glad to do your telehealth management for you. There's telehealth companies that will do it for you or do it for you on a weekend. How many units are you going to need? That's another big question. 10, 30, 50. When you check with your vendors, make sure you ask them what their minimum order is. How often can you get one replaced or cleaned? And again, who's going to be installing those units in the home and who's going to be de-installing them? Again, decisions. I'm going to go through this exercise pretty quickly. And I'll be glad to help anyone offline if they have more interest. If you don't, I don't want to overdo it. This is actually an exercise that is conducted with agencies when they're looking at buying technology. And what it is called a competitive strength analysis. And it's kind of a tool to nothing else. I mean, it comes out with a numerical readout. Really, the purpose of it is to foster discussion within those purchasing agents within your organization. It also is a valid, objective way of going to your board, going to whoever's going to help finance this and say, Now, we've looked at all these options. This is what our exercise brought us. This, we think, is the best technology for our organization, for our patient population, and for our bottom line. So what sometimes what I do is have people do this as a team. And what you're going to be doing is within your organization, you're going to have a discussion of what's the most important things that you need in a good telehealth technology for your organization. You know, first, cost and price decision, and this list is not exclusive. You probably have many of your own thoughts, and it's fine. You can put whatever you want when you do this. What's important? Of course, price is usually the most important thing. Is it user-friendly? What kind of service comes from the vendor? Do they give you technical support? Do they give you clinical support? If you're new at it, you probably want those. What's the company's history? I had a conversation with a friend the other day about how many telehealth companies we've seen come and go in the last 10 years. Is it interoperable with your electronic medical records? Big issue. How much is that going to cost? What are the features? Does it provide education? Can we change the programming from the central office? Is the language, can we get different languages? Does it come in Russian, French, Chinese, Spanish, whatever you might need that? And also, is it translated on the back end so that when you see what patients answer, the questions that go out to the patient, do you know what they are in English on the back end? How easy is it to install? What connectivity is important? Hotline, Bluetooth. Originally the peripherals were wired. Today, most of them are either done through Bluetooth or some other means of, I think, infrared they're doing now, connectivity, so there's less wires. What data are you going to get to it? And what else is important? So you can see in this first one is you're trying, and this is normal, when you're trying to add up everything, it needs to add up to one. So all these categories, however you break them down, your total should be 1. So if you're doing this in your head, if you're doing it on a sheet of paper, if you're planning on doing it after this conference call, what did yours add up to? If it's not exactly a total of 1, you have to go back and reevaluate. So here's one, which now you start thinking about it, well, maybe the cost isn't quite so important. Maybe it's really more important if it's user-friendly. Oh, the interoperability is huge. You need a reliable product. So you can go through, and I'm not sure the whole slide showed up in the translation, so my apologies. This one should total 1. And remember, what did you decide on? Again, I know I'm going through this really fast. What did you decide on? What's important about your technology? Once you've done that and you know what you've differentiated, what the important critical components are, you want to score your product. And this is really good if you can go to a trade show to do this. I know many times home care agencies cannot pay to go to the full, trade shows. Some of the bigger ones, such as HTA, and I'm not plugging them, I'm just using them as an example. I think it's $50 to go to the trade show only. Some of your state associations may or may not offer that option. And certainly it would be easy to go for a day, less expensive. Look at the technologies on the floor, hands-on, maybe easier than inviting a vendor to come to visit you, at least in a preliminary basis. So you want to look at least 3 products to start. You can do this as a team. You can do it as a discussion. You can do it individually and compare notes. You want to assign a value for each selected feature. 1, not so good. In other words, if it's the most expensive product, if it's outrageous, you're going to give it a 1. If it's a really, really inexpensive product, then it's going to have a high rating. And again, do not rate these, do not compare them to their value. It's just strictly pure price. The other piece I'm going to say, when you look at technologies, Be realistic about what bells and whistles you really need that are going to provide value. One thing I've often said is that the data is all the same. So if you're getting the data you need, even though some of the things are nice and they're kind of sexy or pretty, do they provide value? So we're going to put this into an Excel spreadsheet. I hope nobody's asleep yet. In the first column under weight, you have what you've chosen as the relative or comparative values of all these different things that you've looked at, ease of use, education, the price, integration or interoperability, the support. Those are what's important. In multicolored, the green and the yellow columns, you've weighted your vendors. So each one is independently of that weight. So you've gone and you've weighted all those, and now you're going to see, okay, which technology should I buy? And it turns out that for your purposes, and in this case, you can see the cumulative weighted scores in the bottom. It would be number 2, based on your scores and what you think is important. You see that number 1 is a 5.75, number 3 is a 5, so it's pretty much eliminating number 3. But if you go through someone else again, and I'm just giving this as an example of how things are different, if the price and cost position is only 0.25, you're going to see that all of a sudden the first two, vendor 1 and 2, become close enough that maybe you need to take a second look. Number 3, this shows even more strongly that number 2, based on what you've decided is important, is absolutely the best technology for you. And it's hard sometimes when you look at different things within these technologies, when you talk to different salesmen and you develop, specific personal feelings sometimes about them. I think it really helps to look at kind of something on paper that's kind of supporting your decision. So I'm going to stop here for a minute and take any questions. I went through this really quickly. If anyone has interest, I'll be glad to go through this with you offline on a phone call sometime. Do you have any questions?
Thanks so
I
much,
probably
Alexa.
talked way too fast.
No, actually, you've done very well. We have a couple questions that did come in, so please, if you have questions, go ahead and type them into the chat or the Q&A box, and we'll address them either now or we'll address them a little bit later as well. Our first question comes from James. Many older patients are not as computer literate. What is the best way to give them technical assistance?
So we're talking about patients who are not computer literate. So I think we need technology savvy, because typically we're not using computers, although some of the programs with tablets, you might say, are computer-based. I think you just have to look for the technology that, one, is the simplest for that population to use. The second thing is to provide your home care agency. You have a nurse that's going into the home. The nurse can help train the aide or a family member. And that's one thing when I mentioned that if you have an aide or a family member or even a neighbor in the home that can be supportive. I mean, a lot of times we find our home health aides are the biggest champions of this technology. There's even training programs for aides to help them understand the different technologies. So I would suggest that just some, nurse education, aid education is the right technology.
Great. And I can also add a little bit more with that too. What I have seen be very effective as your agencies, if you have existing technologies and their need replaced, and you have a population that is less technology familiar, that may be one of the things that Alexis had told you. You may need to make a higher score for that type of a device so that you
right.
would complement that. So, think about that even in replacing some of your monitors you may already have.
You know, one thing we did, and again, and this was a specific product, we actually went to a nursing home and called a bunch of patients in and asked them, you know, just politely, as we were getting coffee, which of these are the easiest for you to use? And it was interesting. I mean, it was not a formal study or anything, but those are the kind of things that, you know, might help you when you're choosing different kinds of technology, you know, whether it's buttons to push or visual. You know, many of the technologies are very small screens. They're difficult for people to see. Even the buttons are confusing.
Great. We actually just had a question come in, and you just answered it. What do you think about having patients evaluate the technology? So that sounds like it's a win-win to getting their input.
Yes. Yes.
Okay, we have another question from Stacy, and she says, have you observed much pushback from patients with telehealth, such as older patients who may be intimidated by the technology, or those who miss the physical touch involved in healthcare and the personal interaction? And how is this effectively addressed?
Well, there's different aspects to that. The overall rule I found is that once patients, you're going to have a certain number of patients that aren't going to accept it. And hopefully your screening and your nurses will know who they are. However, you know, I've seen providers who've gone and told patients, this is what we need to take care of you. So it doesn't become a question of asking. It becomes a question of saying, you know, this is like a stethoscope. This is what we need. To keep them engaged with it, with some patients it's difficult. They get bored with the questions. So you want to have something, they get bored with the process of it, so you might want to monitor how often you ask questions or how often they're asked to use the technology. I think we find, again, this is a lot of different answers, that almost universally the patients like the extra attention they get when they're on a telehealth program. And they're not losing the surveys and the studies we've had at, you know, exit surveys. They really feel like they receive more home care or more health care. They've come very close to the telehealth nurse. And even yesterday I was in a meeting where the patients were calling the nurse before she even got to call them. So they have another point of access or another level of care.
Great.
But having said that, you do get a patient here and there who just doesn't want anything to do with it, and so be it.
Great, Alexis. So far, that's all of our questions that have come in, but please continue to send your questions in through the chat or the Q&A.
So this is, I guess, we don't have any questions on that tool precisely. It's a great objective tool if you are getting into that purchasing point. So let's talk for a couple minutes about staff. What's your staffing model? You know, the telehealth champion has always been like the probably for 10 years, the code word for the good nurse who's out there who believes in telehealth, talks to patients into it, brings the staff along. If you need, is an unbelievably valuable person to have within your organization. It's, you know, if you're starting a telehealth program, I think it's helpful if you look for volunteers rather than pressing it on someone who's resistant. Because it's really, you need that positive startup energy. Team effort, it depends on whether you have, again, it depends on how large your program is, whether you have one nurse managing 10 patients, 15 patients. When you start getting to the hundreds of patients, then you're going to have a different model. You may have an oversight, you may have a telehealth nurse managing the patients, but then dealing with those patients' case managers. So that's a different, that's a different way of looking at it. If you're dealing with, say, a managed care company, if you're doing management for them, and we all hope that we'll be able to develop that model where we're managing for managed care, there may be a different model because you're just handing off the information to the other organization's care manager. So you're just doing first level of triage. You're not doing the entire clinical piece. You're not in the position of recommending change for that patient. That's their case, the other organization's case manager. So it's just a slightly different way of setting up your telehealth program. 24/7, this is something that gets debated all the time. Do we need to keep it 24/7, 7 days a week? It depends on your program, your preferences, your patient population. It may take a lot of resources. Many of the vendors will be happy to monitor your patients for you on the weekends, but you have to look at the cost of that as well. If you're just learning, if you're a small organization, you might think about it, or if you have another home care agency that you're friendly with, you might want to talk about collaborating, which is something I think is not done enough. We're too competitive. Who's going to be doing the oversight? Remember, there's a huge quality improvement part of this, so you want your quality improvement department involved in this. What are people's credentials? What are their experience? And, of course, what's most important is what their attitude is. And, again, who do you have for backup staff? A lot of the smaller programs start with one nurse, but what happens when she's sick or goes on vacation? What are your resources? Again, it may be helpful if you're small to work with another organization. So, okay, I'm going to do this quickly. In some states, Medicaid pays for telehealth. Managed care is slowly and painfully beginning to pay for it. Hospitals are now getting involved in it. You might want to look at your hospital or your ACO about managing. Here in New York, they have some really good programs going on where they're using telehealth because they're concerned about their hospitalizations. And I may be wrong, but I believe in Texas, Medicaid is now paying hospitals to provide telehealth. So if you're in Texas, you might want to look at getting a piece of that. And again, there's this general move towards capitated payment. I'm going to talk about that now. And the one thing I'm going to say here, and then I'm going to move on, is that people say that Medicare does not pay for telehealth. It does not pay for a discrete piece of telehealth. However, Medicare gives you a budget of money. And if within that amount per episode, if you can save money by not doing nurse visits, if you can improve outcomes by not having hospitalizations, you're going to have to look at cost savings, not cost expenditure. And I have friends who would argue that you can do it under Medicare, you can do it much more efficiently. You can also get data to document research. If you're looking at research, if you have a patient's vital sign data, you can literally show and document that this patient is not ready for discharge. The question is, within Medicare, can it save you money? Again, cost for savings, quality outcomes, and yes, have you heard about this? MedPAC is now proposing to impose readmissions penalties on home health care agencies. So you might want to take a look at that. We know that the underserved populations are very, very expensive population to take care of for everyone, and that's a very fragile population. Again, as you're going to look at your budget, just look at this. If you're trying to be objective about whether or not you can afford to do telehealth under Medicare, if you don't already, just start thinking about, okay, how many visits can I save using telehealth? One of the advantages, of course, of telehealth is as it does allow you to do clinically driven visits, not just calendars, so maybe your front loading could be just, eased off. Again, some final thoughts. Can telehealth and remote monitoring help you, especially if we're moving towards readmissions penalties? 4 highest states, I'm not going to mention them. Probably some of you, I'm sure some of you live in them. Their highest hospitalization rate was 38%. The worst quartile is 58%. That means a quarter of the agencies had hospitalization rates that high. that's really some work to be done. I'm sure they're dealing with a lot of very difficult populations. Those are the ones that telehealth can certainly make a huge difference with if they're, the right patients in the right place. I remember talking to someone who provided telehealth services to an Indian reservation that did not have power. They were using solar panels to provide electricity to those units and cell units. So, it's just amazing what you can do if you have that opportunity. So, final note, again, you want to look for partners with your telehealth program if you want to make it fiscally sustainable. Hospitals, of course, are getting increasingly interested. Doctors, I think, need to partner. I don't think there's so much a partner financially, but obviously you want to look at them from a clinical endorsement. They're a great source of referrals to you. And also you want to talk to them about how much data you're going to give them when their patients are telehealth patients. We hear a lot of complaints from doctors that home care agencies just deluge them with unwanted paperwork. So you want to talk to doctors about how much and when that report is required. ACOs are going to be a major user of telehealth. Managed care, managed long-term care plans, we kind of need to work on that from an advocacy perspective. Community health centers have been providing telehealth for a long time, usually under grants. And again, partners, other home care providers, probably one of your best sources for collaboration, for cost sharing, especially if you're a small agency. It's tough to take care of 10 telehealth units with one nurse over a period of time. So that's the end of my presentation. Sorry to talk so fast. And I guess we can take more questions.
Absolutely. Thank you so much, Alexis. And if you have some questions, go ahead and please put them into the chat or the Q&A. I'm going to hit, while we wait for some questions, on a couple key points that you brought up, Alexis, that I think are really important. You brought up small home health agencies, and we have a lot of small home health agencies that are on the call today, as well as within our country. A lot of times they complain of having a lot of connectivity issues from being in a rural or frontier area. Are some of the newer models of telehealth, Alexis, better with access related to that technology?
Well, I think what we're finding is multiple means of connectivity that may not suit everyone's needs. Obviously, internet connectivity, new models are coming out that use internet. However, many elderly do not use the internet. So it becomes a question of, will a cell, MiFi, or hotspot work? And it does. We have areas here in New York where they don't work. And again, finding the right one, whether it's, HHQI or Sprint or Verizon, they're all different. So I think everyone is really working on that. We have some are now running through your computer, just strictly computer. Some require additional, it's a standalone unit from your computer, but yet uses the internet line. We, of course, have the world-famous POTS lines, which many people no longer have. And then you have the cell connectivity. So we're getting more variation, but there's no easy answer. Some of the store and forward, and by store and forward, I mean it's not, and I didn't really discuss this, it means the information is not transmitted right away. That can actually go out in a kind of text message modality. But again, you have to have that where you are, where those patients are. The store and forward goes over landlines. So there's no there's no universal answer, and there's no absolute answer yet.
Okay. And I think that comes back to the earlier point, too. Really, it is better to have a variety of equipment within your organization because there are different unique patient needs, as we talked about, the patients that maybe don't have the computer skills or the technology skills, I guess, more correctly, but also finding the devices that might work. So perhaps if you live in one of those rural areas, then talk with the vendor about testing it in some of the areas that you know are going to be problem areas.
And I think, one thing I don't want to forget about is that, many people do telephone management. Mm-hmm. They do telephone management as a step down from telehealth, and have people self-report. IVR does a lot of self-reporting, so you don't have to have that computer skill. You need to be able to pick up the phone and say yes or no, or my weight was 145. Of course, how honest people are is, of course, part of that issue. But that does not require any specific skills other than a telephone.
And that is what I have seen. I've seen some agencies when they're replacing some of their telemonitors, they're picking different monitors. But in a lot of cases, they've supplemented too with the IVRs because they had such a waiting list of getting people onto their telehealth monitors that they were able to accommodate more people by using the IVR for those patients that would do well with that device versus the telemonitor.
And I think you make an important point. Different types of devices work well with different types of patients. And what you're seeing, if you go to a trade show and you look at different equipment providers, you're going to see that they're going to have more than one now. It used to be that, a company had one product or maybe two that were relatively simple or similar rather. Now you're going to see this plethora of, if your patient lives in a rural area here, we can give it, IVR if they don't have a phone or if they don't have this. But if they have internet, then we can give them this tablet and they can use that. Or if they're, standard and they have a POC line, we can do the old-fashioned little box where they can answer questions. So you have just that variety, which is wonderful. I'm sure it's going to increase.
Absolutely. And I think our opportunities, you've brought up so many great opportunities. We do have opportunities, but creating these collaboratives is essential to do that now as our ACOs, our medical home models, and all of those are formulating, as well as, I'm so glad you added to the slides about the PAC recommendation to have penalties for home health for their readmission rates as well. We knew it would be coming. So we really have to utilize and leverage everything. So the technology really can help us if you learn. And this is one of the biggest problems I see with a lot of agencies that I've worked with. They introduce the telehealth, they get it up, they do the champion, they do all of the good things that you mentioned early on. But the problem is they don't change the visit pattern. So it's very expensive that way.
Yeah, one thing I was going to mention, the senator, and actually maybe I can just put this link in the chat box, but for those of you who really want to look at your business model, the Center for Technology and Aging in California has initiated a return on investment pilot, and they're actually looking for home care agencies to participate. They're going to help with data collection. They're going to help you look at your, that balance that you're talking about between labor costs and technology and how to make your technology is too expensive, for example, or how that fits into your business plan. So if you're interested in that, I just put the link up. David Linneman is the head of the project. They're very invested in helping home care providers. It's free help, and just keep that in mind. Free help is not to be sneezed at. It would take a little time to fill out the tools that they have, but I really don't think it's anything too expensive, and they'll start helping you get your data back as far as your return on investment.
Perfect, and that really plays into setting up a business plan for expansion or starting telehealth. I do have a question from Edmund. Who primarily do you consult with normally?
Well, mostly providers. And I'll tell how actually I met Misty Misty Kevich a couple of years ago. We actually developed a program with some of my colleagues here in New York called Telehealth Certification, where we would help providers, try and understand almost what we're talking about here, but much more. It was a whole day long program where we talked about all the clinical and the data and the program management. So I've primarily worked with providers. I'm now actually working both with a large provider and a technology company, so that I'm kind of bridging that gap between what the provider needs, what the patients need, and doing the product development to support those, kind of like innovative new pieces that hopefully we'll see coming forth in the next few years. But primarily providers.
Thanks.
And I've done a lot of work with the state of New York as well, I should throw in.
And honestly, I have attended their conference, and they were really doing technology to the fullest, or, well, not the fullest, but to the most advanced in the whole country in New York. And they were thinking out of the box, and leadership was like, we're going to make this work, but we're going to find ways to make it cost effective, and we're going to keep they took a look at their return on investment, and they were able to truly make a good business case to continue the program. Okay, I'm going to go ahead and move on to the next couple slides. I don't see any additional questions here at this point. So we'll move to just to give you a couple resources for HHQI in our cross-setting 2, which is it has a section on telehealth information, and Paula Suter from Sutter VNA did write a piece on telehealth in general. So if this is something new or you want a little bit more information about some of the terminology that was used in today's presentation as well, it's a good resource to look at. There is a leadership checklist, some telehealth resources, as well as Dr. Steve Landers, who has been a very proponent of home health and using technology. He also wrote a piece in that setting to be kept as well. Next page, or next slide, please. Okay, there we go. This is just on our Next Up Network call, which I think could tie very nicely into diabetes as well with the telehealth component. But April 9th, from 3 to 4, we have Everyone with Diabetes Counts, the impact on rural southern West Virginia. This is one of, I believe, 2 projects in the country with the QIO that is doing a diabetes-focused program. And Natalie Tappy is going to be with us, and she's going to talk about that, and it's very applicable to if you live in rural or urban areas. But they also are they have a lot of issues related to doing self-management, get patient activation and engagement. So all of the things that we're doing ourselves, so you can register for that. Next slide. Also, we have the gravity of falls. Falls is another hot topic, a lot of hospitalizations and injuries and changing quality of life. We have an evidence-based preventative strategies webinar Tuesday, April the 29th. It is available. You can go ahead under webinars on our site to go ahead and sign up for the presentation. It's from 2 to 3 Eastern Time. We'll cover multifactorial fall risk assessments. How do you determine if you need to adjust your thresholds? Look at implementation of interventions for clinicians in the home. They'll also talk about medications. We'll have a pharmacist that will be one of the presenters. So we'll be having therapists as well as nurses and pharmacists on this call. Next slide.
Okay. Misty, do we have a question, or Shannon, I'm sorry, do we have a question up there? I'm just, I can't tell. It looks from my box we have another question before you close off.
No, I always come back because we always get questions at the end. And so see if Shannon or Misty, if you see another question. All of mine have been answered.
Okay.
We always get them in at the very end, so that's why I'm trying to make sure.
Okay.
Yeah, it appears to me that they answered.
Maybe he's gone, yeah.
There we go, Shannon.
Yeah, I didn't see any others in the queue right now.
All right. I think that is probably the last of our questions. If you do think of an additional question, please do email myself, or you can email and contact Alexis. She did give you her information. We do utilize the tools that she's built right into the presentation. She is one of the gurus in telehealth and really has great vision in how to utilize and make telehealth a component that is effective for reducing hospitalizations and improving patient outcomes. So we were very pleased and very much thank you, Alexis, for coming and presenting today for us.
Well, thank you. I love to talk about telehealth, as you know. I just think everybody wins with telehealth. So I really enjoy being part of that world.
Well, thank you again, and thank everybody for taking time out of their day today to join us. And we do hope that you'll be with us again in 2 weeks.
Okay. Thank you.